Removing the lower stomach in a distal gastrectomy leaves the surgeon with an immediate anatomical problem. The digestive conduit is severed, and gastrointestinal continuity must be carefully restored. This diagram maps the two primary solutions to that problem. The surgeon can route the gastric remnant down one of two pathways. On the left, the stomach connects directly to the duodenum. On the right, it connects to the jejunum. These two options represent different architectural philosophies. The first option maintains the normal physiological sequence of digestion, while the second executes a complete bypass of the duodenum. The exact geometry and structural routing chosen in the operating room dictate how the system functions decades later. Each specific anastomosis creates a distinct set of mechanical and biochemical failure states. In a Billroth I reconstruction, the stomach is sutured directly to the duodenum, allowing food, bile, and enzymes to mix normally. However, poor blood supply or excess tension can cause the suture line to fail. This anastomotic leak is the most feared early complication. When gastric contents escape the GI tract, they flood the peritoneal cavity. This triggers generalized peritonitis, rapidly progressing to sepsis, shock, and multi-organ failure. Even if the suture line holds, the junction remains highly vulnerable to other immediate threats. Patients may experience vessel hemorrhage, delayed gastric emptying, or paralyzing vagal nerve injuries. The Billroth I approach succeeds by maintaining the body's intended physiological routing. Its primary vulnerabilities are local, depending on the physical integrity of that new junction. Regardless of the reconstruction chosen, the pyloric sphincter is permanently lost. The physical valve metering food out is gone. Without that valve, early dumping syndrome can occur within 30 minutes of a meal. Looking at this intestinal cross-section, a concentrated bolus of food rapidly enters. To dilute this sudden concentration, massive amounts of fluid shift out of the surrounding blood vessels directly into the intestinal lumen. This rapid fluid transfer strips volume from the patient's circulatory system. They experience sudden hypovolemia, intense intestinal distension, tachycardia, and severe diarrhea. This chart maps a delayed crisis, late dumping syndrome, occurring hours after eating. The rapid transit of food causes an aggressive spike in blood glucose. In response, the pancreas releases an overcompensating surge of insulin, driving glucose levels far below baseline. This rebound hypoglycemia manifests as sudden weakness, profound hunger, tremors, sweating, and syncope. The missing pyloric valve also works in reverse. Without a physical barrier to prevent retrograde flow, alkaline duodenal contents wash backwards into the stomach. The corrosive bile salts damage the gastric mucosa, causing chronic epigastric pain and bilious vomiting. Removing the pyloric valve transforms the stomach from a controlled reservoir into an unregulated conduit, altering the osmotic and endocrine balance of digestion. This diagram details the alternative approach, the Billroth II reconstruction. Here, the surgeon sutures the transected duodenal stump completely closed. The stomach is then connected directly to a pulled-up loop of jejunum. This architecture forces all ingested food to bypass the duodenum entirely, creating two operational pathways. The jejunum segment carrying food away from the stomach is the efferent loop. The segment carrying bile and secretions from the closed stump is the afferent loop. The Billroth II design establishes a complex multi-limb plumbing system. By separating the food and enzyme pathways, it creates a pressurized architecture with new vectors for mechanical failure. The first mechanical threat is a failure of the closed duodenal stump. A stump blowout is often fatal. When that stump ruptures, the consequences are immediate. The duodenal constantly fills with bile and enzymes. A leak floods the peritoneum with corrosive fluid. Further down, mechanical obstructions like kinking in the bile-carrying limb cause afferent loop syndrome, building rapid internal pressure. Trapped secretions distend the loop, causing severe pain until built-up bile forcefully breaches into the stomach, relieving the pressure. If an obstruction forms in the food-carrying tract instead, we see efferent loop syndrome, where food backs up directly into the gastric remnant. This presentation mimics a gastric outlet obstruction. Because the blockage is strictly in the food tract, the patient experiences early satiety and vomits undigested food, completely free of bile. Separating the pathway for food from digestive enzymes transforms routine mechanical kinks into critical, loop-specific pressure emergencies. Bypassing the duodenum also creates stagnant stretches within the jejunum. This stagnation fosters pathological bacterial overgrowth, known as blind loop syndrome. These bacteria deconjugate bile salts and consume nutrients, driving chronic steatorrhea, diarrhea, and progressive weight loss. This map illustrates malabsorption. Iron absorption is strictly localized to the duodenal mucosa. Because food bypasses this region, patients develop severe iron deficiency anemia. Simultaneously, reduced intrinsic factor drops vitamin B12 absorption, while altered flow impairs calcium absorption, leading to systemic osteopenia. Unaccustomed to a highly acidic environment, the jejunal mucosa can ulcerate when exposed to continued acid secretion. The most severe late-stage complication emerges 15 to 20 years post-surgery: gastric stump carcinoma. This malignancy is driven by the structure of the Billroth II. The chronic reflux of bile washes over the gastric stump for decades, forcing repeated mucosal injury and cellular regeneration. Executing a complete duodenal bypass trades immediate digestive continuity for decades of malabsorption and a heightened oncological risk. Both Billroth reconstructions successfully achieve the immediate surgical goal of restoring gastrointestinal continuity, yet their specific architectural choices dictate different clinical trajectories. The Billroth I approach preserves duodenal transit, which restricts its major postoperative threats to localized junctional failures and the consequences of losing pyloric metering. The Billroth II approach forces an entirely different geometry, rerouting normal physiology to create a pressurized, bypassed system. Comparing the two models side by side shows that the Billroth II architecture is uniquely susceptible to severe loop obstructions, chemical peritonitis from an isolated stump leak, widespread nutrient malabsorption, and long-term malignancy. Managing post-gastrectomy complications involves analyzing the GI tract as a dynamic system of applied fluid dynamics, mechanical pressures, and long-term biochemistry.